Buenos dias, everyone. We are going to go ahead and convene this joint committee session of our Health and Human Services Committee and Education and Culture Committee. I am joined by my colleague and friend, Councilmember Jawando, from Chair of our Education and Culture Committee, as well as Councilmember Sale and Lutke, and Councilmember Mink will be here shortly. This morning, we will be discussing the recommended FY25 through 30 Capital Improvements Program and FY25 Capital Budget, Department of Health and Human Services. But there is lots of crossover with our Education and Culture Committee, and that's why we are here this morning. So I will, without further ado, turn it over to Ms. Yao to tee this up and give us some context, and then I will ask my colleagues from the executive branch to please introduce themselves. But we'll start with Ms. Yao.
So the Joint Committee is here to talk about CIP projects that involve partnership with the school system and or are education related. So there are going to be 5 projects that the committee will review. Those are the 3 childcare renovation projects, the high school wellness centers and expanded wellness services project, and the school-based health and linkages to learning centers project.
Wonderful, thank you. If our colleagues in the executive branch could introduce themselves, we'll start with Dr. Bridgers.
Good morning, HHS Chair Albornoz, EC Chair Jawando, and council members sitting this morning. We are eager to start the discussion. I am joined by Ms. Treadvans and Ms. Martin, our great team from our children, youth, and families, who put a lot of time and input into this CIP, looking at strengthening our support to our Montgomery County Public School partners. Also, Mr. Hodge is joining me now, who has intimate knowledge on school-based health and wellness centers, and others may join as the council begins their question and answering. It is an opportunity to really take a deeper dive in looking at all of those responses from the executive committee that we put into this improvement program.
Wonderful, thank you. Mr. Dice.
Hi, David Dice, Director, Department of General Services.
Wonderful. I'd like to turn it over to the chair of our Education and Culture Committee. Oh, go ahead. Why don't we go down the line? I thought, let's go down the line. Ms. Treadvance.
Good morning, everyone. I'm Dira Treadvance, currently serving in the role of Chief of Children, Youth, and Family Services in HHS under the leadership of Dr. Bridgers.
Thank you, Ms. Treadvance. The work that you and your team are doing has never been more important than right now, or more challenging. So thank you so much for your continued commitment.
I'm actually not HHS. I'm Adrienne Karamihas. I'm the Director of Capital Planning for MCPS.
Wonderful. Thank you.
Good morning. I'm Monica Martin, Senior Administrator for Child and Adolescent School and Community-Based Services. I will be listening today. I did get Invisaligns recently, so please have empathy. Serving under the leadership of Dara and Dr. Bridgers and HHS.
Thank you.
Grace Pedersen, the Office of Management and Budget.
Hello. Mr. Hodge.
I'm Mark Hodge. I'm the Chief Operating Officer for the Department of Health and Human Services.
Awesome. Everybody knows each other now. This is great. Councilmember Jawando.
Thank you, Chair Albornoz. Good morning to everybody. These are, I just want to say, these are, as Councilmember Albornoz mentioned, these are some of our most important programs. There's a lot of ways we support our children and our youth and our students and our families, and many of those have nexus with HHS, so we're really happy to be co-convened. And at a really tough time when we can't find enough people to do these jobs, folks are stretched thin, but we also have ambitious and important goals like expanding wellness centers to every high school. I know we'll get into all that, but so it's a really important discussion at an important time. And Ms. Martin, we couldn't even tell you had the Invisalign until you said something. So yeah, so I know. My daughter's in her retainer now, and so you're more self-conscious than most other people are, but that's just how it goes. But really happy to be here and appreciate all the work you're doing, and look forward to coming up with some really good recommendations today.
Thank you. I have an Invisalign too, and I want to come back as an orthodontist. So thank you. Ms. Yao, if you could go ahead and get us started. We'll go through these one by one, colleagues, as we always do.
Okay. The first projects that are for the committee to review are the child care renovation projects. The former child care renovation project has been recommended to be separated into 3 projects, each dealing with ADA remediation, child care facility replacement, and playgrounds. I think that, again, this was split apart for administration and tracking purposes. Taken together, the total amount for the fiscal year 25 to 30 period for the three projects is $40.481 million. This amount, coupled with the $9.267 million, which is provided in the original project for work going through fiscal year 24, results in a total increase of about $2.526 million, or 5.3% from the approved 23 to 28 project. The first project to consider is the child care renovations ADA remediation. The PDF is at circles 1 to 2 of your packet. For the 6-year period, the CE is recommending $8.136 million for the project. The recommended funding source is GEO bonds. Requested 25 appropriation is $1.227 million, and the estimated 26 appropriation is $800,000. This project provides for the renovation or replacement of child care facilities to remedy features that are non-compliant with the ADA. And the following table on page 2 shows the estimated project schedule and costs for the ADA remediation projects. Council staff recommends approval.
Thank you. I'd be remiss not to mention that this past weekend, a number of my colleagues attended a very thoughtful presentation from Action in Montgomery that convened a number of community stakeholders to discuss early childhood and education, and that follows the wonderful work that's being done both within county government but by a number of other stakeholders, and it just underscored the urgency and the interest in this topic. And I know we're all on the same page and wanting to advance as many opportunities as we can, and the capital component of that is important. Did any of my colleagues have any questions or thoughts on this particular item? If not, then without objection, I think we will support the recommendation.
Okay. The next one is the child care renovations, child care facility replacement project. PDF is at circles 3 and 4 of your packet. The total amount for the 6-year period is $22,771,000. Recommended funding source is GEO bonds. Requested 25 appropriation is $3.543 million, and the estimated fiscal year 26 appropriation is $2.242 million. This provides for the replacement of county-owned modular child care facilities. The intent is to bring these facilities into compliance with accreditation standards, and the table on page 3 of your packet shows the estimated project schedule and costs for each of the projects. Again, council staff recommends concurring with the executive's recommendation.
Great, and colleagues in the executive branch, chime in at any point if you'd like to add anything, but I don't see any questions or comments from colleagues, so, Councilmember Sales?
Okay, so I see that we're looking at the remediation schedule.
We're on B.
Yes. Our office received quite a few calls about some of our child care facilities. And I believe we followed up with questions about improvements to some of our child care centers, especially our early care childhood centers, and wanted to know if there were any efforts to follow up with how many other schools are still on the list awaiting.
If I may just ask a clarifying question, was that sent to HHS?
It was sent to Ms. Yao.
So, child care is this kind of complex
Yes.
system in the county, and there are various types of programs that are offered in various types of settings. These, I think, the concerns that were raised have to do with services that are being delivered in MCPS facilities, and so they aren't connected to this particular CIP project, but I don't know if MCPS wants to chime in about the specific concerns. I think it was one of the early care centers that I think we had constituents writing in about.
Yes, it was the Up County Early Childhood.
Yeah, I'm going to yield to Councilmember Jawando, the Chair of Education and Culture Committee. This did come up in that committee.
Yeah, we'll take that one up. So we have the upcoming. I was just there yesterday, actually, and so that's the one we've been hearing a lot about.
Yes.
It's in a holding facility, an old
Yes,
building that
exactly.
needs a lot of work. There has
Yes.
been work done. I'm sure you were going to say this, but
Okay.
that's not these projects. But we will
Okay.
talk about that just to flag for you.
I guess my
Thank you.
comments related to that.
And
too.
Councilmember
Yes.
Lukey.
Okay.
So thank you for making sure that's on the radar. One of the other issues that has come up is about the portables that are behind the Up County Early Childhood Center. Right now, they're boarded up and other assorted things. And when we were at the Action in Montgomery event on Sunday, I'm thinking through here and going, one of the reasons we don't have capacity for 3 and 4's programs is space. But yet there's this host, and it's like over a dozen portables back there that are not being used currently. And so to the extent that, again, we were talking about both HHS and education and culture related issues, if somebody can follow up on that to see what kind of maximization of those existing spaces could be used and deployed in other areas to build capacity, that would be great. Thank you.
Thank you. Although this did come up in the Education and Culture Committee, for the benefit of my colleagues on the HHS Committee, does MCPS have any comments now, or do you want to follow up?
So we can follow up, but just to say that because it is a holding facility, so the last school that was there was South Lake. South Lake has over 800 students, so the reason why those relocatables are there are to house students that go there while their building is being renovated. And so we do have projects that are on the list that are included in our CIP. So we do have to look at, and we can absolutely take a look at the safety of them, can we do something else? But if we take them off and then the next school that goes in needs them, then what we're doing is we're paying to take them off to put them back on. But certainly we can take a look at it.
Great. Councilmember Mink?
Thanks. Yeah, while we're on the subject, just wanted to give a plug to Joanne Lelick needing early childhood space as well. I know this is something that a number of us have talked about, and I'm sure that you have heard, but that's a big need in that area, and so want to make sure as that project comes together that that there's an intentional look at the need there, at the data, and that we're not just kind of arbitrarily saying, okay, one classroom, or that we're really looking at the numbers of the families that we need to be serving there and seeing what's the very best that we can do at the school, and what additional partnerships might we need in the area to balance that out. Thanks.
Great. So thank you for that question, Councilmember Sales, and the points, colleagues. I think without objection, then, we support the committee recommendation for item B, childcare renovations, childcare facility replacements. All right.
Great. The next project is the childcare renovations playgrounds project. PDF is at circles 5 to 6 of your packet. For the 6-year period, the executive is recommending $9.574 million in GO bonds. The requested fiscal year 25 appropriation is $1.235 million. Estimated fiscal year 26 appropriation is $821,000. This project provides for the renovation or replacement of child care playgrounds at existing facilities to ensure compliance with the ADA and also child care accreditation and safety standards. The table on page 4 of your packet shows the estimated project schedule and costs for replacement for these projects. Actually, there's a typo there. For each of these playground projects. And again, council staff recommends concurring with the executive's recommendation.
Don't see any questions or comments from colleagues. This one made me smile. But I think without objection, we will support that recommendation.
Okay.
Oh, Councilmember Jawando?
I agree with that recommendation. I had a question I wanted to ask related to the ADA. I know we're still approving it. Are there other, is this the end of the list, or are there other places that need ADA rehabilitation as far as the child care in this context? So you obviously have this longer list here that we're doing the playgrounds. On the ADA list, does this round us out, or will we be compliant in all, with ADA for all of the child care centers or places that you're staffing, or is there a longer list?
These are all of the child care centers that have had identified ADA noncompliance issues.
So this is the list.
This is the list.
So once we do this, we'll be compliant.
That is the objective.
That's the
yes.
goal and
Yeah.
objective. Great, awesome. Thank you very much.
Councilmember Mink.
Thank you. Just wanted to check in, if you know offhand, for these playgrounds, when we're talking about ADA compliant, does that necessarily imply that we're looking at like rubber surfacing and that kind of thing, or do you know where we're trending for what we're using on the ground?
I was waiting for that question. Playground surfaces are always a subject of debate. Yes, these are fully accessible surfaces, usually a rubberized material, virgin rubber or other types that you see characteristically are installed in all of our recreation facilities, which are ADA compliant as well, that ensures open, unfettered access to all of the equipment for all of the users, maybe not just children of the playgrounds, including ADA accessible playground apparatus itself. So, yeah, the surfaces typically are a tiled virgin rubber material that's very resilient, UV resistant, and modular so that it can be replaced as tiles are worn out.
Okay, I will follow up. Interested to learn more. I do generally have concerns about rubber surfacing because we know that there is data about various types. You're smiling, so I know you know what this conversation is. But certainly there's concerns about how hot they can get, about carcinogens, about impact on environment. I was just at a playground the other day with my kids where this is an MCPS playground that I won't name, but it's one of many, of course, in the country. It was installed a while ago, but it has the rubber surfacing, and the bits of it are not only flaking off, and it's every time I go there, flaking off right around the edge, but they cross an entire basketball court. They go down a ramp and they reach a soccer field below. And that gets swept up, and then within days it's back. So
well, we can follow up with you. We have done fairly exhaustive research on playground surface issues. The type of surface that you're referring to, we had installed in the past. We no longer install anymore because of the flaking and deterioration that occurs, particularly along the edges. But we'll follow up. I can give you some examples, some sample sites you can visit and see for yourself.
Appreciate it.
You bet.
I have a few things to say about this particular topic. I'll yield to Councilmember Sales and then I'll chime in.
I appreciate the discussion on the turf and the surfaces. I had questions about the uptick of mental health concerns that we've been hearing. And I know that our middle school students, I know we're going to get to the next section, but have we thought about any mental health improvements with regards to the equipment or the projects that we're conceiving for these playgrounds?
Our focus has been on, again, ADA accessibility and recommended playground equipment, replacing and upgrading the equipment that's there. I don't know that I'll defer to my colleague, Dr. Bridges, on any mental health issues.
So thank you, Councilmember Sells, for that question. I would have to follow up with Dr. Santiago and our Behavioral Health and Crisis Services team, who's really looking at all of the mental health challenges for our adolescents and school-age children. So this may be one space that we need to follow up and really put some additional emphasis on.
Thank you. Sounds good.
I'll just connect a quick dot there. So the playground spaces undeniably contribute to positive mental health because it really encourages health and wellness, exercise, activity, play, creativity, all of the above. And I know that our Parks Department and our school system have been very intentional about seeking out the best of the apparatuses that are out there and the play equipment that's out there. That is both fun but also somewhat challenging. And so I appreciate Councilmember Sales' point. Again, just my old rec department hat is just something I happen to know a couple of things about. And related to that, I very much appreciate Councilmember Mink's point, and this has been understandably a point of conversation and discussion in the community. We did extensively look at different surfaces across the county. And it's really challenging because in order for wheelchairs and other apparatuses to be able to easily access the playground equipment, there's not anything out there yet that is exclusively an organic material that complies with the needs that we've heard. And we had the Commission for People with Disabilities serve on a committee that investigated this matter, and we went about as far as we could go. We have made great strides. It's certainly far from perfect, but the new materials that are out there in particular do much better absorb the heat, which is among the more serious concerns. But the environmental aspect of it is still something that the industry has to catch up on, and one that we're committed to looking for the best products available, but it is a challenge. But without objection, then I think we will go ahead and approve that and then move on to the next item. Ms. Yao?
Next item is high school wellness centers and expanded wellness services. This project provides for two types of facilities. First, the high school wellness center, which places comprehensive health, mental health, social services, and family support and youth development services. The second type of facility, which is for mental health and positive youth development services, came about in acknowledgement of the struggles that youth have been facing both pre and post-pandemic. At this time, all schools have access to mental health and PYD services, and new spaces for this programming is planned at high schools that are undergoing major school construction and are not scheduled for a full high school wellness center at the time. For the 6-year period, the executive is recommending $15.152 million over the 6-year period for high school wellness center projects at Springbrook, Paint Branch, Woodward, and Damascus high schools, and mental health PYD spaces at Blake, Magruder, and Crown high schools. The PDF for this project is at circles 7 to 8 of your packet. The table on page 5 shows the breakout for each of these projects. Springbrook is the only one that is a standalone project, meaning that's not going to be planned and built in conjunction with major school construction. For the recommended funding sources for the 6-year period is $14.152 million in GEO bonds and $1 million in state aid. There is no fiscal year 25 appropriation request, and the estimated fiscal year 26 appropriation request is actually a negative appropriation of $4.350 million. Council staff notes that the expenditures shown in that schedule may need to be adjusted based on the actual school construction schedules that that either exist now or that will exist at the time of CIP reconciliation. So the Joint Committee, when considering the fiscal year 23 to 28 amended project, indicated that expansion of these comprehensive high school wellness center projects would be based on need rather than the MCPS school construction schedule, and requested that DHHS perform a comprehensive analysis of need to determine the priority order for constructing these comprehensive centers, as well as convening the school-based wellness center planning group to finalize these priority recommendations. The table on page 6 of your packet lists the ranking that they came up with physical health factors considered in that ranking. And whether it also shows whether the executive is recommending a school for a full high school wellness center or mental health PYD space during the 6-year period. There are a number of factors that executive staff, I think, considered in developing this plan, and for contextual context, council staff highlighted them on pages 6 to 7 of your packet. First is disruption to the market for care provision. DHHS considered high school locations that are geographically distant from existing school-based health and wellness centers in the county to increase access to care for uninsured students and to avoid disrupting local markets for community-based providers. With the addition of 4 proposed centers, the county would be operating 20 sites in the county, and that's more than any provider in the county. And the department is concerned about saturating the healthcare market that may lead to negative effects on local pediatricians, federally qualified health centers, etc. department staff has indicated their intent to actually change the eligibility policy beyond school enrollment and care for kids recipients to all uninsured high school students. The department is also interested in expanding access to school-based health and wellness center services through telehealth options. The committee may want additional information about the timing and implementation of these changes. I understand that this is, I think, the plan, but I don't know, but I wasn't sure about, or I didn't hear about, like, when these things would happen.
Great. Maybe we can hear a little bit from the HHS first to affirm what Ms. Yao was talking about and fill anything that may have been missed, and then if we can talk about the construction schedule, and I have some comments before we get to that. But Mr. Hodge, looks like you're ready to chime in here.
I am. So when we were looking through the data for all the high schools, and council had requested that we put together a more comprehensive data analysis of all the high schools and where need may play a factor in future high school wellness centers. When we were doing that, it was still with the impression that we would continue to move forward with a wellness center in every high school. In discussing that and in looking at the data, access to care in many of our high schools, I'll speak just to the somatic piece, the physical health piece at the moment, places like BCC or Whitman or other schools where they have a highly insured population, and knowing that even in our existing wellness centers, we don't see a lot of insured students in our wellness centers to get physical health care because they have access to their own pediatricians or other health care. So as we were looking at the priority list, and on the second page, you'll see some of the factors that we looked at in determining our priorities. We looked at what the need was, and we did look at, because according to state law regulations, the definition of a high school or a school-based health center includes physical health services. And so for us to move forward with a high school wellness center and continue to call it that, we would need to include the physical health component in all of the high schools that are on the list. As Ms. Yao said, we are at risk of saturating the market in a county of 1 million people. To have 20 clinic sites is pretty remarkable, especially when we have 2.5 federally qualified health centers who are also providing services here, and a large number of pediatricians in the community who are providing services to those who have insurance. And so in looking at the priority ranking and deciding which schools to actually put a full high school wellness center, we looked at geographically. So while that wasn't a request for us to look geographically at where we should be placing high school wellness centers, it is clear, and thankfully Springbrook and Paint Branch are near the top of the priority list. Springbrook is at the top of the priority list. Those are both in the East County, where we don't currently have any school-based health or wellness centers at the elementary school or the high school level. And so we wanted to make sure that we were addressing that need as well for something in the East County. And so pushing forward with a full wellness center at Springbrook and Paint Branch address that geographical need, as well as the actual access to care and other needs that were prioritized in the list. So we were concerned about that, but we also knew that our Bridges to Wellness program that we put into place a couple of years ago is really working well. How do we enhance that in the high schools where we're not necessarily putting a physical health component, but we still need to include mental health and positive youth development, and potentially enhance those services in every high school where we don't already have those services being provided. And so to address the potential saturation of physical health concerns that we had, as well as addressing the mental health and positive youth development needs for all high school students at this point. This is the proposal that we came up with. To address the telehealth potential, there are still uninsured students in every high school. There are still students who don't have access to care in every high school. But rather than putting a somatic health component in the high school, we are now pursuing the ability to provide telehealth services at those high schools without a wellness center, who can access a provider at any of our 20 sites, 16 currently, but future 20 sites, a provider at an elementary school or at a high school, either through telehealth or because of the placement of these sites across the county. Many of them, Einstein and Blake were pointed out, they're both, Einstein and Blair were pointed out, they're both literally within 5 minutes of a high school wellness center site. And so if they weren't going to use, or if they needed on-site care versus telehealth care, it is easy access to those providers already in person. And so it is, we are pursuing the telehealth, we need equipment for that, we're pursuing funding for that, and we will need to update our policies that we currently have, which we are working on, that really limits currently the eligibility for students who are in that particular school, elementary school or high school, to have access, or care for kids who are assigned there. So we are opening that up. We are going to expand our policy to allow any student, any uninsured high school student, to be able to access our services through telehealth who might be outside of an existing wellness center.
Thank you. I have a few comments. First, I need to acknowledge our former colleague and friend, Councilmember Navarro, who was the lead in making sure that we moved in this direction, which, of course, the previous council, and I'm sure this one as well, acknowledged the urgency and the challenges that we're having in this space. Kids are hurting everywhere right now, regardless of where you live in this county. And even those children that are fortunate enough to be insured, as we are seeing, that insurance coverage is often not enough to cover the care that's necessary, and of course it even more disproportionately impacts students who don't have any health insurance at all. So I fully acknowledge the complex jigsaw puzzle that you all have to put together with the resources that we have, and so I appreciate and respect the thought you all have provided in making these recommendations. There's no perfect solution here, and I think we all understand that. I did have just a couple of questions before turning it over to Chair Jawando, and I'm sure other colleagues will have questions too. I know that Woodward High School will be coming online soon on Old Georgetown Road, and I know that will offset, it's intended to offset some of the overcrowding that we have at Walter Johnson and BCC and that down county cluster. Was that new school taken into consideration when looking at the rankings?
It was not, only because we don't know what the boundaries are going to be for that high school. And so the way we were doing our analysis was really based on zip codes and census tracts, and not knowing specifically what was going to be, which student population was going to be attending Woodward. We did not include that, nor did we Crown, for example, is also in the same Crown High School, which is now being built. We don't know where the boundaries are for that either. So neither of those high schools were included in our analysis for looking at a full wellness center. However, there is a full wellness center that's being built at Woodward simply because Northwood is about to close and move to Woodward for 2 years while Northwood is being rebuilt, and Northwood already had a wellness center. So there is a wellness center being built. We have been in discussions with MCPS about how to, if we choose in the end not to have a full wellness center at Woodward, which I imagine we will not need, just based on the population of the current students, that keeping the PYD mental health side of the center and repurposing the somatic side for another classroom once Northwood moves out back into their new space. So while we didn't use the Woodward as part of the analysis for our rankings, there is currently a wellness center that's being built there.
I appreciate that. And just one more comment before turning it over to colleagues. I really want to acknowledge MCPS is here as well. I see Mr. DJ Connolly in the audience. I know there's been a lot of collaboration with HHS, but particularly the administrations of the schools themselves. This was a curveball for our colleagues at MCPS 2 years ago, and they have handled it very well and appropriately. There was a collective decision made by the joint committees then that obviously in a perfect world we would want a full wellness model in every high school. They all deserve one, but there are practical realities of space limitations, of need, and so we tried to thread that needle, and that I think provides some of the context for why we have these recommendations here now. I will turn it over to Chair Jawando, and then I've got Councilmember Mink, followed by Councilmember Lutke, and then Councilmember Sales.
Thank you very much, and I appreciate you making that last point, because just so for the millions watching at home, as I like to say, obviously there was a special appropriation in 2022 that Councilmember Navarro led and the full council, the previous council supported, and part of that was to fund money in the CIP to plan out what it would look like to have wellness centers at every high school. I mean, that was the intention at the time. Obviously, we're here today, and we had taken previous action to say, like, well, is that what we need to do? Is that realistic? And so we're having that discussion. So just want to frame that. I think the somatic. You mentioned Northwood, which was the first wellness center and heavily used. Visited there last year, and so it's a good thing that Woodward would have that. So just to state what I think you're already saying, just to state it clearly. The vision as you currently look at our 25 high schools, the list of where there's going to be a full wellness center and where there's not, could you just we see parts of the list here, but have you made that full determination with MCPS partners yet? And I know that's a tough question because some schools are moving and all that, but you talked about Woodward, Northwood, but
Right, so we did rank all 25 high schools and put a placeholder in for Woodward and for Crown as well, just not knowing whether we were going to continue to move in the wellness center at every high school concept or not. The schools that are in the bottom 16 or 17, not in the top 10, are all, the vast majority of them are in the Rockville, Bethesda, Chevy Chase area, where we have a large number of high income and very low numbers of uninsured students who attend those high schools. There's also schools like Poolsville and some other schools where Clarksburg, for example, that also have that skew more insured than uninsured. That didn't make the top 10, but from a geographic standpoint, that's where when I was thinking about when we were thinking about this, is that would they potentially have access geographically if they couldn't get access in their own school? Could they somehow make it?
And by access, you're referring particularly to the somatic physical health care needs, correct. Because every high school will have access to the mental health PYD components.
Yes, as it does now through Bridges to Wellness. Right. But yeah, we would enhance and expand
but an enhanced version.
Yep, absolutely.
Because obviously all of our kids are dealing with mental health challenges at every school. And okay. Yep. So if I were to restate, you have the top 10 where you envision a full wellness center with both somatic and mental health, PYD, and then the rest will have bridge to wellness type, maybe some expansion that you talked about, including potentially telehealth. Did you answer the question of how soon that's going to come online? I know Ms. Yao mentioned that, but I didn't hear. I don't know. Maybe I might have missed it.
The telehealth piece?
Yeah.
We are, like I said, we are pursuing funding for the telehealth equipment, and we have to change our policies. I would expect that we would try to pilot that this fiscal year, that we're FY24. FY25 coming up. And then with what we learn, and as we get more telehealth equipment, to be able to, because we have to train people on it as well, that we will have all of the high schools by the end of next year, the FY25, involved in this process.
And when you say pursuing funding, is that going to be before us in this budget, or when you say pursuing funding, what does that mean?
Well, it was not
Outside
in the
funding?
It's not in the FY25 operational budget, simply because we didn't know what direction we were going to have to go. But we are likely to need to seek, and telehealth equipment is not very expensive, so we may need to seek a supplemental at some point if we're not able to get grants or assistance from the state. The state is interested in this as well. We do get funding from MDH for our high school wellness centers and school-based health centers, for that matter. That potentially could be applied to this as well. We're in contact with them about funding, helping us to fund that as well.
Well, I'd recommend to my co-chair and to the staff that we come back pretty soon on that issue in particular. Obviously, those access to those services and expansion of those. Every school I go to, I know my colleagues, you hear mental health, access to services, and we want to have as many, I know you all know, lanes as possible for people to get into there. Some are comfortable coming in and talking to somebody, other people aren't.
Right.
So, dear Dr. Mrs. Treadvance, I see your...
Ooh, speaking it into existence.
Yeah. I was prognosticating to the future.
One point that I also wanted to ensure that there's clarity on, so the current ranking, as Mark explained, is for the somatic side, right? And it's strictly focusing on ensuring there's services for uninsured students. That's the priority. When it comes to the other side around what schools do we prioritize for either mental health or positive youth development services, the rankings might not necessarily look the same because the indicators we look at for that, the aim is very different, right? On the somatic side is to ensure access to medical care and obviously there's a strange symbiosis when it comes to mental health. That's the one that's a little bit more complex because there's an interconnection with somatic and behavioral health, and then also positive youth development and behavioral health. But just wanted to preface that ranking will not necessarily look the same because we look at completely different indicators and the goal is completely different.
And do we have that ranking?
We did put that together, but we're happy to go back and have a conversation, and if y'all want to see it, we could do that. But
yeah, I would love to see it.
There's stuff that I think we need to come internally to the table and kind of reassess and reevaluate depending on where these outcomes land us.
Because that could be helpful in a number of ways, right? Like not just this conversation, but what other services out of school time. I'm looking at my dear friend, Ms. Martin, and the whole group. Like all that stuff is going to matter for those indicators as well. Okay, I think I just had one other question. The program of requirements of the spaces hasn't been finalized yet, is my understanding. So what's but the packet that Ms. Yao put together, which is beautiful as always. Your packages are so good you can just read from it and it's perfectly clear. So so it's like that there's a roughly $2 million construction cost, which is only slightly less than the lower end of the Wellness Center construction themselves. Is there an estimated operating cost for the mental health PYD spaces?
So we're finalizing the POR for that now. It is a pretty complex document that requires, the full wellness center is 15 pages, so this will be a little smaller. We do have square footage. DJ and I have been working from MCPS, are working on that now, and he'll be able to get us some cost out for that fairly quickly as soon as he has the finalized POR.
Okay, great.
So I would think within the next couple of weeks.
Great. Love to see that. Obviously, it'll be great to see that before we finalize everything in May. So, all right. Thank you. Thank you, Mr. Chair.
Thank you. So again, I've got Councilmember Mink, followed by Councilmember Lutke, and then Councilmember Sales.
Great, thanks. So to be clear, we're talking about a shift away from the strategy of placing the full high school-based wellness centers everywhere, and shifting to some places doing bridges and some places doing wellness centers, just to be okay. And that is driven by concerns about market saturation. Is that right?
And total cost, yeah.
Okay.
And I would say also need and efficient use of resources.
Yeah. So, okay, I'm just trying to better understand this. On the market saturation front, is there, The wellness centers are intended primarily, right, we're talking about our underinsured and our uninsured folks. We're putting those in, we've been putting those in because we're concerned that there are folks who are just not accessing the care that they need and the quality of care that they need. So those are folks who are not going and accessing that quality care through private practices, regardless. So why would we be concerned that it is taking business away from private practices?
I don't think we can say that they're not accessing care through an FQHC or through the ERs where they're getting care.
Or quality care, right? Regular care, primary care.
Which is why we know that occurs. And so for them to be able to get access in a site that's not in their school and opening up the access through telehealth or through the ability to walk in to an existing wellness center hopes to address that. And our high school nurses and school health staff will be presented with all of this information and training on how to make those referrals, how to use the telehealth equipment that will be placed in their schools so those students can access that.
Right, but I mean, telehealth is not, and I'm not necessarily arguing one way or the other. I just want to make sure that I better understand like the arguments and the data on the table here. So we're saying that those. So, well, my original question still stands, right? Those uninsured and underinsured folks, we're providing wellness centers for them so that they can access that physical care, the somatic care that we do not believe that they are accessing through, primary care or visiting their primary care physician. Like that's not like a thing that's happening. That's why we've got the wellness. So we're not taking business away from private practices. We're taking business away from ERs, which continues to be a very good thing to do. We have huge problems actually with our ERs being overwhelmed, especially in areas like East County. Right. So I'm just trying to understand why we're looking at market saturation as a reason, as like one of the marks in the column of why we should scale back services.
So we're not only seeing uninsured students in the wellness centers, the wellness center and somatic services and otherwise are open to all students in the school, regardless of their insurance status.
Sure.
So if our insured students are accessing their healthcare services through the wellness center and not through their normal pediatrician or going to an FQHC because they have Medicaid, then we're taking that potential reimbursement away from the FQHCs or the private provider. So it's not the uninsured students specifically. It's because we have a 2,000.
It's the insured students.
It's the insured students who are accessing health care. Rightfully so, that they have.
Right.
They're certainly eligible to do so,
Do we have
and it is
numbers
convenient.
on that?
I'm sorry.
Do we have numbers on how many insured students?
Yeah, we do.
Okay, and so are those numbers kind of what drove this conversation, or were are private practices, reaching out because they're saying, oh, we're having patients who are not returning to us, and we believe it's because they're accessing care at schools? Like, what's kind of the driver here?
Yeah, so I've not heard complaints necessarily from private practices or even the FQHCs for that matter. It simply is a numbers assumption that by putting a clinic in 27 sites across the county that accounts for 80,000 students or more, or 75,000 students or more who have access to it, my assumption is that's going to start eating into those healthcare providers. I don't know if they know that what the plan is to open these, or if they've even noticed or paid attention. It's me anticipating that may be a problem in the future.
Okay, so we want our private practices to flourish. We need more of them. We need people accessing primary care. Like, all of those things are absolutely true. We also don't want to remove access to care there are underinsured and uninsured students who are in those schools. And like, let's just be realistic here. Telehealth is not the same, and saying you can walk into this in your school is absolutely not the same than saying, oh, you could drive a few minutes away. That is the difference between going to get care and not going to get care for some number of students. I don't know what the data is exactly, but we're making assumptions. That's an assumption that I would make, and that I think it would be important to have some kind of data to understand, there. And then, but like I said, our private practices are important. We want more of those and we want them to flourish, but I'm just not convinced that this is actually a problem for them. And so, if we're not hearing from them, we haven't been here, like private practice that's right next to a school with a wellness center, that, private practices aren't reaching out and saying, oh my gosh, I heard from so-and-so, like, please don't build a wellness center next to my private practice. Like, that's not something that we're hearing. I'd be interested to look at the data of how many insured students are seeking care there, but I would say also that the question there would be, and this would be, difficult to decipher, but the question there would be, now, are those kids accessing care because it's there, because it's so convenient and so easy that they just would not have otherwise? Or are their families really being like, oh, even though we've spent your whole childhood going and taking advantage of our insurance and building a relationship with this physician and accessing our primary care there, because it's in your school that you'll be attending for 4 years, we'll just switch and we'll do everything there? How much is that really happening versus now we've got kids who they probably wouldn't bother to go to the doctor, but they're right there, so they're going to go check in and take care of this situation. Like that honestly seems a lot more likely to me. And so this is a really big decision. It was a big decision to have the strategy to put these wellness centers into place. But the executive branch and the council supported it at that time for some very, very good reasons. Now the budgets are tight. We should always be reevaluating and refining, and completely, I agree. We should be willing to change course when we have data that tells us to do so. I am just not seeing great data here that tells us we should be making this big a decision, and potentially one that has a negative impact on our most vulnerable population. There's a price tag attached to everything. Everything should be analyzed, but this is a big one to be making big decisions about based on some assumptions. The bridges are the. Oh yes, I'm sorry. Please.
Just to comment on the budget impact. So in our operating budget impact assessment of these projects, we estimate that the cost per site is about $1.1 million per year. So I think this year we're trying to appropriately scale it, that if we're looking at 20 sites throughout the county for a total population of 1 million, and the number of students served at each high school is a subset of that 1 million, that's also my understanding of part of the market saturation, is that 20 clinics countywide at a cost of 1.1 million. We just want to make sure that we're using our resources effectively and strategically. So that's also behind this approach, that maybe mental health and PYD are the most urgent need at these other sites, where somatic care is not as urgent at those other lower priority sites.
I hear and respect that. We need to be budget conscious. That's just the reality of the situation on the ground. I just want to make sure that we're using data rather than assumptions if we're going to talk about making a dramatic change in course. I appreciate the suggestion that we come back to talk about this more. I think this is a big deal. I think that we need to make sure that communities are very aware that this is a discussion that's on the table, because we've been having schools that are clamoring for more, not clamoring for less. And there is a big price tag. To completely understand that people clamor for a lot of things and we can't afford everything. But we need to be making data-based decisions, and we need to make sure that we are including the community in that conversation. The community and those who are, having the most interaction with them, our PYD folks, for example, are going to have some of the best intel on some of the questions that are a little more squishy that we're talking about here, in terms of what kinds of services are maybe our insured students accessing and why, versus how might that be impacting how they're showing up to their private practitioners, that sort of thing. But I think that I just want to emphasize that this is a big deal, and I think we need to really dig into this and make sure that we're being very thoughtful, and that we're making a decision that we can very clearly defend to communities that are going to really be disappointed. And so I appreciate that we're coming back to this. Would love to dig into this a lot more. And then last question on this. So the current intent to where we're putting in PYD and mental health programs, are we talking about maintaining the same level of PYD services and of mental health services that we have in the wellness centers? There's just, so we're just kind of cutting away the nurse practitioner piece, the physical and somatic side of things, but we are left with the same quality investment in both PYD and mental health. Is that accurate?
Mostly accurate. So without the somatic piece, without the nurse practitioner who might be able to do some case management, or the medical assistant who may be helping with referrals, there's a slight increase in number of staffing that we would use for a mental health PYD model only. So what's existing in Bridges to Wellness now would be enhanced with a positive youth development piece that doesn't clearly exist now in our Bridges to Wellness program, but also adding other case management assistance that is not available because there's not a nurse or a nurse practitioner or a medical assistant.
Okay. So yeah, when we come back, it would be great to be very, very clear about exactly what the proposal is to include at a Bridges site, in a wellness center, and exactly what data we're using in order to kind of make a cost evaluation. And I think it's really important for us to find ways to bring the community into this conversation, because again, they have been getting the impression over the years that something is coming. We're calling it, Bridges to Wellness. In my mind, part of that was because this is a bridge to getting a wellness center. So now this is like, a dead end sidewalk, but like, don't worry, it's a good thing at the end. But like, we've been saying something, and if we're going to change that, we've got to be very, very clear and very, very intentional. So I appreciate looking for cost savings. I hear you. It's a lot of money. It is. It's a big investment. But health is pretty foundational. So let's just make sure that we are very intentional.
If I may clarify too, what Bridges means is, you got it. It was exactly that because we couldn't have a wellness center in every single school at the time, the pressing need was mental health, access to behavioral health services. So what was proposed as an interim approach was that the 16 schools would have, we would leverage current contracts that we had within CYF so that we can add and include an additional clinician and a case manager. Would you say that that's a correct definition, Monica?
That's what the executive proposed,
Yep.
and then Councilwoman Navarro added a youth development practitioner at every site. And then we also have half-time PYD presence through Mr. Luis Cardona's shop through his school outreach network.
In those 16 schools. So just wanted to be clear that Bridges is 3 staff, and then
Three and a half,
Three and
if
a
you
half.
will, and at 19 schools.
and in
currently.
19
Yeah.
schools. So if there would have to be a conversation, if more staffing would be needed, because obviously one additional clinician and also one case manager for an entire school is a lot. So
Absolutely. Yeah, thank you so much for that clarification. And I think that this is a conversation, like these are difficult conversations to have with the public when we're talking about balancing budget against things that they want and need, but that is what we have to, that's what we have to do. And we're going to get better information and be able to make better decisions if we bring them more into the conversation. And sometimes we're going to have to deliver bad news, and sometimes we're going to deliver good news, but I think that we should do that together and as transparently as possible. So if there's sites that are now, we're talking about potentially them getting something different that they were expecting, that again, we need to be at that school having those conversations and be very, very intentional and transparent about how the decisions are being made and why. Thanks.
So those are really, really, really good points. And when I saw market saturation, I had a similar feeling. But I want to make a couple of points because I think it will help sort of provide a little bit more context on the conversation. So during COVID, I was shocked at how many private medical providers almost went under. And we actually ended up having to, and they were primarily pediatricians, and we ended up having to provide, under Dr. Bridger's leadership, we formed a work group that helped to open up conversations between DHHS, our clinics, both county run but also run independently, and our private providers. And it was around COVID, it was around vaccinations, but I think served as a really important template moving forward, because Councilmember Mink is right, and we all know that just because a private practitioner is out there not only does it not mean that everybody who even has medical insurance is accessing that particular private practitioner, but it also doesn't mean that they're getting the quality of care or the extent of care that they may need. Because we know how many people are underinsured, have insurance, but are still underinsured. So I think this presents a unique opportunity that will take some work, but where we do bring our public and private stakeholders to the table and look at our entire system of care with this as, you know, a school-based model, but that looks holistically at the entire geographic area that's within a reasonable distance of these particular clusters. That, I think, is, you know, would get to the systems change that I think we've all acknowledged we need, and that we need to stay in front of, and will help better inform us as we make these difficult decisions so that they're not based on assumptions, but actually on quantitative and qualitative analysis, which I think would be really helpful. The other two components I want to make here are the actual physical structure of the schools is majorly challenging because, you know, we're not talking about just, you know, simply adding another space or shifting around existing spaces. There are obviously very significant licensing requirements in order to be able to have this type of somatic care within a school, and that brings with it tremendous capital challenges on a school-by-school basis. And so that, to some degree, went partly into the decision-making here, although not particularly stated in the packet, I know was part of the equation. It's just a practical reality. But the other challenge here is staffing. So build it and they will come. You know, everybody is clamoring for the same nurses, for the same social workers, for the same medical providers. And I'm not even getting to culturally competent. And so that's another area where I think we have an opportunity here to raise all boats. Because even just, you know, building these wonderful and acknowledging important facilities at every school, if we could, we may not even be able to staff them unless we really think aggressively there. So just wanted to make those points. And I chimed in, and so I'm going to turn it over to Councilmember Lutke now, and then Dr. Bridgers, I see you wanted to make a comment. If you can hold on to that after Councilmember Lutke, I'd appreciate it.
Thank you. And as someone who has espoused the benefits of telehealth for a great many things, because it does help. It helps bridge a lot of issues, a lot of gaps, and particularly in the mental behavioral health space where it's clinically appropriate, can really be a huge benefit, especially to our teens trying to access care and accessing care in a way that they relate to. That being said, even whether it's a pediatric practice or adult internal medicine practice, what my experience has been, and I have the benefit of having, you know, private insurance through my government job here and previously at the state. I've never lived in Howard County, but my pediatricians are in Howard County. My internal medicine doc is in Howard County because that's where I was able to get care at that time and form that doctor-patient relationship. The number of people you call who say we can't take more patients is really high. To add on to that, a lot of pediatricians, in order to manage their practice loads, have certain hours that are for their ongoing, whether it's their annual physicals or whether they have children who have to come back repeatedly for med checks, or they have ongoing chronic health needs and they only have a certain slot for acute medical needs. I've got the flu. I need to know, is it flu, is it COVID, is it strep, right? That's the holy trio that everybody deals with now every winter. And you can't get an appointment. And then they're closed because they don't do evening hours. And so then you see at the urgent care facilities, the wait times are really high if you're lucky enough to have an urgent care in your area. And they'll take you in, check you in and everything and say, well, we can run the test and then can you leave? And then we'll hook you up with a telehealth appointment after you leave. Is that okay with you? So we're seeing a lot of, you know, trying to plug the leaks in the dam all over the place. So I think there are a lot of things about the whole ecosystem of both preventive medical care and having an acute need that needs to be addressed where we're struggling based on our existing systems of care. So how would you envision DHHS would expand the access to these services via telehealth? Like, have there been discussions about the parameters for which telehealth would be appropriate, a protocol for referral for, and where they get referred to next if they have to have diagnostic testing done?
So when we're talking about, when I've been talking about telehealth, it's really been specific to telehealth for the somatic care. I've not had discussions yet with Monica or with Dira about how we may be able to also enhance mental health services. However, there will already be mental health available in every high school. And so whether there's telehealth needs there for someone who's at home and we have a larger number of truancy, larger amount of truancy happening, and maybe if we can get them on their phones through telehealth into the health room or into the mental health space, maybe that would make a difference. But that's certainly something we can look at. But from the somatic side of it, there are certain protocols for when a student walks into the health room currently, into either the high school or the elementary school where we have a clinic, that the nurse, the school nurse, makes a decision. Is this something that we can treat with a Band-Aid and send back to class? Can we give them a Tylenol and send them back to class? Or do they need to see the nurse practitioner? And it's in those cases where they need to go see the nurse practitioner that we would also look at this as a telehealth moment. That the nurse may be able to say, because we have a standing order at the wellness centers for Tylenol or ibuprofen or allergy medicine, that the nurse could just do that and send them back to class. If it's something that would need to be is more complex and needs to see the nurse practitioner, and they're not at a school where there's a nurse practitioner available, but there is through telehealth that they could then be connected with that nurse practitioner online and figure out what's going on. If there are diagnostics that would need to be completed, we would have to transport them or have them transport themselves to that wellness center or school-based health center to get their blood drawn, to send it to labs, things like that. It hasn't been fully fleshed out, but there are the obvious opportunities that we have are pretty clear.
A school nurse can do the COVID test, though, correct?
Yep.
And so can they also do flu and strep?
Yep.
Right, because then,
on-site testing is,
for those types of things, understanding phlebotomy is a separate issue, right? But for those types of things where, it's going to tell you one route or the other for care, that could be a referral to a nurse practitioner who then can get on the telehealth and talk to the student about if it's strep, we're prescribing antibiotics, this is what you're going to get, this is where, we'll figure out how you're getting it picked up. But in the Bridges to Wellness, you talked about it focusing more on the behavioral health side. Especially in teens, but it happens in adults too, the behavioral health issues affect somatic health. So, if you've got a pediatric patient who's suffering from anxiety, their stomach may be having some very acute symptoms. There's a whole lot that goes on with that, right? What's the protocol now with the Bridges to Wellness to be able to address that, or is it just not addressed because they're focused only on the one part and there aren't referrals made for the somatic byproduct of the underlying behavioral health issue?
Yeah, that's a great question. I just want to remind us all, like we were just talking about, that there's a school nurse at every school, and that is a partner in every school. So whether we're talking about Bridges to Wellness or linkages to learning, we always work to make sure that those staff are connected, that they're collaborating regularly. And in many situations, of course, behavioral health practitioners, it's a best practice to ask for release with primary care or other physicians that are working with that youth to connect the dots for holistic care. So Either or are options, but it's certainly wonderful to be able to walk down the hall or down a couple of halls, right, to visit the school nurse together if need be.
Yeah. I just know that the school nurse, 9 times out of 10, when there's a stomach-related issue, unless they're actively throwing up right then, there's no call other than to say, I've got so-and-so in the health room, they're going to lay down for half an hour and go back to class. So that's not getting to the, I have to treat with something that's ongoing as we're also managing this behavioral health issue that's contributing to the digestive problems.
And if I may, I think in some schools that might play out organically. There might be that organic interplay, but to your point, I don't think it's standardized as a protocol. So that is something that would be depending on where these decisions land. And we are talking about bridges and expanding positive youth development. That is something that we would have to dig our heels into and really develop a more stronger relationship with school nurses, and to be able to develop standard protocols where at least questions are asked. Well, is there something trouble? Where the nurses could at least, because they are gatekeepers.
Sure.
You're absolutely right. I've said it before. I'm like, when my daughter is feeling nervous or is anxious, she doesn't say, Mommy, I feel anxious or I feel this. She says, Mommy, my tummy hurts. Right. So those are definitely, we would have to standardize those as protocols so that we're not leaving things sort of up to organic chance or relate on the relational level, but dig it a little bit deeper into protocol.
And given we know all these things are going to take time and money and we're working through it all, I think that's something we need to do sooner rather than later, because the sooner we standardize that as a way to handle it based on the resources that are available currently and maybe for several years as these other things are put into place, we need to make sure we're closing some gaps. I know there's a recommendation I'm going to talk specifically about Damascus High School. I know there's a recommendation to tabled decision-making on that one, where a high school wellness center has been recommended. Respectfully, I disagree with that, based on the needs of the area, based on the geographic location, based on the discussion that Councilmember Mink just had with respect to market saturation. There's no market to saturate up there, right? So, and you're talking about a spot where the students are far away from any other schools, and there's no public transit. And then I looked at the chart that included, as opposed to the old chart that had the just demographic kind of based things, and then the new chart, which included the actual health metrics, the health and mental health and positive youth development factors. Damascus actually moved up in the rankings of need, not trended the other way. So I think given all those factors and fully respecting that there's a separate CIP discussion that needs to be had with that, I would ask that we not table decision making on that facility. So thank you.
All right, so that's a motion. Is there a second? Not hearing a second. Nope. Amendment does not pass. Ms. Sales.
Thank you, Chair Albernals and Jawando. Just wanted to talk about the wellness centers, the telehealth option. I know since we haven't brought these on, it's hard to tell what sort of improvement or gap this will fill. When I think of the telehealth, we were just talking about how useful these opportunities would be, and I think about more than 20 of these health and wellness centers in the community. Would I be able to go to the doctor more often, or how on demand are these telehealth and mobile clinics going to be? How many would we need to bring on or plan for in the next year to anticipate how well they're going to work? And how much longer will it take to actually implement this whole system that we're going to test out to see if it'll work before we do the full health and wellness centers? And during this time, it's our students who are going to be waiting on these resources. And so I know that there's a ranking for the high schools. I'm just wondering how many across MCPS, how many Title I schools are without health and wellness centers?
So Title I schools are elementary schools, right?
Mm-hmm.
Designated as you're pointing out. And so there are 9 elementary schools currently
Okay.
that have a school-based health center. And I'm actually not certain on how many Title I schools there are currently. 10? 10 Title Is? Go ahead. Okay, thank you.
We had 10 school-based health centers in elementary schools. I was under the impression that they're all Title I schools, but I may be mistaken. Because just based on need, they're probably, yeah.
But I believe the question is how many Title I schools do not have one. And so I see my neighbor here counting the number of Title I elementary schools for you, so we can do the math and get back to you.
Thank you.
There you go, 39.
39.
So 29 without.
Okay, all right. My other question was just about the, just thinking about what the resources would be and timeline for implementation for the telehealth services, or I'm just trying to figure out how this would work, and if we are going to be servicing the uninsured populations, did we do a fiscal note for what this would cost?
A fiscal note for the telehealth?
Well, because we're thinking about expanding this to uninsured populations, and so I'm just wondering how much staff time that will account for. Did we think about that, or?
Not yet. What makes it a little more complex is students who are uninsured, regardless of age, from 2 to 19, may also have Care for Kids. So they're not officially insured because they don't have Medicaid or they don't have a private insurance, but they do have access to care through Care for Kids, which is about 4,000 kids in our community right now. So while they may be officially listed as uninsured, they are assigned to primary care, including all of our 16 sites currently, who are seeing anywhere from 50 to 100 of those Care for Kids kids. So we break it down within the school-based health centers in our data, so we can tell the difference between someone who's has Care for Kids versus just uninsured. But that number is a little lower. The uninsured number is lower in those schools where we already have Care for Kids assigned. We haven't tracked that from other schools where they have Care for Kids who are maybe assigned to a school-based health center or to Kaiser or another provider as well. So it's a little trickier to identify the difference between uninsured versus Care for Kids, but absolutely something we can do and will do.
Thank you, Councilmember Sells. As I sit and take copious notes, and thank the council this morning for all of the insightful questions. And Councilmember Mink, absolutely, we need to revisit some of those protocols regarding the parameters around telehealth. As Councilmember Albernos indicated, during COVID, we had a telehealth protocol. We worked very closely with our MCPS partners to develop that, but the times have changed. And we need to revisit some of those things, as Mr. Hodge indicated, not only the referral systems, but the implications of HIPAA and FERPA, and how that will impact our ability to respond and refer and identify those providers. Dr. Davis and I, Councilmember Alvarez and I had a conversation regarding the secretaries and the state partners that we have now begun to have an ongoing cadence call with them, so we can address issues of telehealth and prioritizations and our school-based health and wellness centers, and looking at all of those things that touch HHS. But I wanted to share those comments before I lost sight of that, and we continue the dialogue. We have work to do in this space, and we recognize that.
I'm finished, thank you.
Thank you. Councilmember Jawando.
Thank you. Just really appreciate the conversation. This was the meaty part of the discussion, so it's appropriate that we're taking this time. Ms. Martin, you mentioned a school nurse at every school, school coverage at every school, right? Because that's a constant issue that we hear about, and I just want to say that because I could see our school nurses like cringing on the video. Where are we on those numbers, right? We talked a lot about the counselor ratios, the school nurse ratios. How has that improved, gotten worse? Is it stayed the same? Mr. Hodge, the nurse on the panel, right?
Yeah. From a school health perspective, we have one nurse in every high school, middle school, and community school. And there are, I forget the number of community schools, but those are all Title I. But it's upwards of 25, or I think now.
I think around there.
So we do have one nurse that is there. That doesn't account for our vacancy rate. It is harder for us to hire nurses at the moment.
What is
we are
our
using
vacancy rate right now?
I'm sorry?
What is the vacancy rate right now?
I believe they have 16 nurse vacancies now, but they are backfilled with maximum temp staff.
Yeah, temps. Yeah, I know, right.
And so we are able to maintain that one nurse per school ratio at the high schools, middle schools, and community schools. There are some elementary schools that a nurse may have 2 or 3 schools that they have to go between, but a school health and tech or a certified nurse's aide in every single school.
Right.
So.
Well, if we could, I don't remember when in the budget, I know we'll get to that on the operating side, so we'll come back to this, but that's just something to think about in the context of this. And Councilmember Sales brought up a really important point around the Title I schools that don't have a school-based health center. I think all of us would want every school to have a full blown out school-based high school. Let's just say that. I would love to see that. I think it would be used and it would be good. Obviously we have to prioritize. Either the community has to say, "Come raise our taxes" to do it, or we have to prioritize, and probably we need to do both of those things in my view. But the 39 Title I schools that don't have a school-based health center, that's another priority here of how are we making progress on that, and not necessarily CIP conversation as much, but partly CIP, and so I just think there are equities here to to how we are providing those services. Did you want to?
I just wanted to add, related to the operating budget for community schools with the one dedicated nurse per school, there's 34 community schools in the county, and there's additional schools that are expected to be identified in fiscal 25. The operating budget includes about 16.9 FTE net increase, which annualizes positions added last year and adds new positions to meet this new capacity that is expected to be identified in fiscal 25. There's also some revenue from the state that will be available to partially offset the cost of those positions. So just to add that, being that there was interest in elementary schools as well from Councilmember Sales and what you just said.
Yeah, appreciate that. So just want to make those points. I turn back to the chair. I know, I don't know, and I'll just want to double down, make sure, please let us know about, one, Ms. Treadvance, to see your list, and then also get back to us on how quickly you think you can expand these services, the PYD, mental health, at these, because that's a factor in this too, right? I think as we're making this big shift. Thank you, Mr.
Thank you. So a couple of comments that my colleagues have made, which have all been very salient, are that, we're just talking about high schools right now, but, there were conversations about middle schools as well. Particularly given the mental health challenges we're seeing at the earliest of ages, but in particular middle school. That is a conversation we're going to have to follow up on and just see where we are. And that will have both operating and capital implications clearly. But it's something we're going to have to get back to. So Ms. Yao, maybe shortly after this budget is passed, if we could reconvene a conversation specifically around middle schools, and to Councilmember Sales' points, elementary schools as well, that'd be great. So I know that, understandably, my colleague and friend, Councilmember Lutke, moved that we not hold on Damascus for very thoughtful and legitimate reasons. Reason I didn't support it isn't because I don't agree. It's just, it's hard with the balance of everything and lifting up one school versus others. It's just challenging under the circumstances, but I certainly sympathize and empathize with your motion. And so it sounds like there is understandably not a feeling of unanimous vote to move, the recommendation forward. So we're going to need a motion here to advance the recommendation. So moved.
Second.
Seconded by Councilmember Sales. All those in favor, please raise your hands.
I'll move it.
Okay, great. So moved as recommended. All right, Ms. Yao?
Okay, so just to clarify.
Put your mic on.
Sorry, just to clarify, the committee's moving council staff's recommendations?
Correct.
Okay,
Yes.
all right. So
And we will revisit this to Councilmember
Yes.
Mink's point
Definitely.
soon.
Absolutely. The next item is the school-based health and linkages to learning center project. Council staff published an addendum to the packet yesterday, so this is, we received additional clarifying information that we wanted to make sure the committee was aware of. So for fiscal year 25 to 30, the executive is recommending $4.354 million over the 6-year period for linkages to learning projects at Silver Spring International and Neilsville Middle School and Greencastle, Twinbrook, and Whetstone Elementary Schools, and a school-based health center at Lelik Elementary School. The recommended funding source for the 6-year period is GEO bonds. The requested 25 appropriation is $1.335 million, and the estimated fiscal year 26 appropriation is $1.742 million. The table on the first page of your packet going on to the second page shows the programmed amounts for the projects proposed in the 6-year period. They include, again, I'm not sure if I mentioned Eastern actually in the top. So what I had said, as well as Eastern Middle School linkages to learning. The Greencastle linkages to learning project reflects an increase of $441,000 from the amended approved project due to a cost escalation. Council staff also notes that adding linkages space for the Twinbrook Elementary School and Whetstone Elementary School sites that do not currently have linkages to learning services is consistent with the linkages strategic planning recommendations, and that's there's more information about that provided later. So as far as the schedule goes, the table on page 2 shows the schedules, assuming that there aren't changes, either delays or accelerations, to when these particular projects are expected to be completed. Council staff does note that the PDF language should be updated to reflect the most recent production schedules for each of these projects, as well as including and basically taking out South Lake because it's already been completed, and then including Lelik. So those are just some description changes that need to happen. As far as the linkages to learning strategic plan, that is attached to the packet at circles 62 to 64. And there's also staff recommendations that are attached at 65 to 70 of your packet. It provides recommendations for elementary and middle school programs based on the number of students enrolled in farms or the percentage of the student body enrolled in farms. They are tiered. So the first tier of schools has 600 students enrolled in farms and more than 65% of the student body enrolled. There's a second tier that has 400 to 599 students enrolled in farms and more than 65% of the student body enrolled. And then the third tier has an existing linkages suite in the school or over 400 students enrolled in farms, but less than 65% of the student body, and then vice versa. So council staff does note that the two schools mentioned before, Whetstone and Twinbrook, are schools that are included in that report. Whetstone is a Tier 2 school, and Twinbrook is a Tier 3 school. In that report, there were identified linkages or other schools in the Tier 1 category that did not have linkages to learning services. And so as part of council staff's recommendation is to consider funding or moving forward with feasibility studies at the schools that are in the Tier 1, meaning that have 600 students or more that are enrolled in farms and more than 65% of the student body. Now, the data that was looked at before may not be current, it may be stale, so that determination may have changed. So council staff recommends requesting that executive staff work with MCPS to identify those schools that meet those criteria. And otherwise concurring with the executive's recommendation for the 7 projects and basically cleaning up some of the language in the PDF.
Councilmember Mink?
Thank you. Yeah, I appreciate the council staff recommendation to that point. Looking at the list there and seeing that we have in Tier 1, we have one school that's marked here for our elementary schools as not currently designated as a linkages learning site, which is Roscoe Nix / Crest Haven there. So I just wanted to see if anyone wanted to kind of speak to that, but also acknowledging I think that council staff makes a good point.
Yeah, absolutely. So our county executive's budget did include those schools that do have a project in the MCPS CIP timeline due to those cost savings. That was the only factor.
Yeah, and certainly I understand that. I mean, it is a different cost analysis if we talk about doing a separate project as opposed to incorporating something into an existing project. I do think that we need to be very intentional then and thoughtful about how we're serving those communities, because now we know that the needs are so high that we wish that we were able to afford to do this for them. We know that it's an unmet need. And do we really have enough services in place? Are there ways that we can enhance what's available to them? And I appreciate the feedback that I've gotten from some of the folks here already about some of the options that we have in front of us. And we've certainly leveraged some of those already and much appreciate them. But the needs are still very, very high. And I think that a feasibility study makes a lot of sense, and making sure that we're using updated data, because again, these are hard decisions and we can't do everything, but making sure we are being very transparent with the public, and also that we're doing a very clear cost benefit analysis. To the extent that even doing that I know is financially feasible, that's a question also, but I think it's a conversation that's worth having. And also want to mention Burnt Mills Elementary School, which has, like some other schools, seen a dramatic shift in population this year. The situation was already fairly dire there, and they're seeing great increases looking at FY25 as well. So they're at 74% farms. With 546 farms students for FY24, and anticipating an increase to 84% farms next year. And keeping in mind that they're a CEP school, so everybody gets the free lunch there, so we can assume that that is a farms undercount to some extent. And so I would expect that they are Tier 1 or Tier 2, and they're not on these lists right now. And the needs there are extreme. We have many, many newcomers who are landing at that school right now. And so lots of trauma associated with that. And I think the community is certainly asking for more support. And so to go and hear, there are elementary school children who are voicing that they need mental health support, and there are parents who are voicing not only that their children need mental health support, but that they need mental health support. We're at the point to where that is happening. I was just talking to one of our community volunteers who happened to mention unprompted that helping at food distribution, serving this particular community, that he was really struck by seeing the hunger in the faces of the community members that were being, and this is somebody who volunteers at many different sites and was particularly impacted by what he was seeing at this site. And so noting that, you know, the data has changed rapidly and this school is very, very high need. They are crying out for help, and so much appreciate the recommendation to make sure we're looking at fresh data, since Montgomery County is a welcoming place and we're striving to be, and people are coming here, and that's great, and we need to do what we can to be agile and responsive to that.
If I can add a note in regards to that, the schools that are named in here were named when this was completed, when the report was completed. And the most recent available data there was the farms data from the 2020-2021 school year. However, when we sit down annually with MCPS to look at their CIP plans and make program recommendations for the department to make to the executive, we are looking at fresh data every year. So your raised burnt mills, of course, they were on our kind of priority list in that conversation, but they did have a CIP project completed, I believe.
They just,
a few years
they
ago.
just had one, which honestly,
Exactly.
like, that's one of my concerns, because I'm like,
Yeah.
oh my gosh, we just missed them, you know, and now this huge influx is landing there. The needs are so high, they're not going to have a major capital project coming up anytime soon. Does that mean kind of within the framework of our strategic plan that they're just, you know, out of luck? Because if we can't afford to do this for them, like, we got to do something else that's better, because the needs are dire. So I'm very, very concerned for, you know, not just this school, but other schools that are in similar situations.
Absolutely, and I want to thank your office for reaching out to advocate on behalf of the Burnt Mills community. So we're aware.
I really appreciate
we're
your
in
continued
tune.
support.
Of
Yeah.
course, of course.
And it would be great to get the updated list and data that I know you all have been looking at, but to make sure that we have that in hand so we can see how these recommendations exactly came into being, and then as we continue to look at the most recent data moving forward. Thanks.
All right, good points. Not seeing any other questions or comments from colleagues on this particular item, so I think without objection, we'll follow the recommendation. All right, anything else, Ms. Yao?
That's it.
No? All right, well, thank you, colleagues. There's obviously a lot of follow-up that we will need to conduct beyond the CIP, and we will certainly do that. I think in my first term, somebody analyzed this, and the HHS and Education and Culture committees had more joint sessions than any of the other committees, and so we're going to keep that tradition going. So with that, Councilmember Jawando.
And also more kids.
Yes.
Then, you know,
That's right.
With 8 plus 4, 12.
Yeah.
12, 14, 15.
Yeah.
Wow.
There you go. 15 kids on the joint HHS
Yep.
D&C committee. So this is the right folks here, baby.
Yeah. That's right. That's right. That's right. I love it. Good point. All right. Well, thank you all very much. With that, we are adjourned this morning.
Thank you. Really, thank you.